So the diverticular diseases, we already had discussion about that the type of diverticular, that is congenital or acquired. The congenital diverticulars usually have a wide neck and have all three layers of that intestine, while the acquired diverticulars usually has the only muscular layers. And usually the diverticulars are present in the mesenteric border of that intestine. And uh, so just one by one, we are going to discuss this. First, the duodenal diverticula. The common site is second and third part of the duodenum inside, inner side, because the mesenteric are not attached to the duodenum. So in the duodenum, it is attached in the inner side. You know the duodenum is coiled, na? Make a C shape. So inner side of the C, there is the diverticulars. That may be asymptomatic, congenital, and acquired diverticular presents due to that long-standing case of the duodenal ulcers. That may cause some problem. That may cause the obstructions, infections, and the perforations. So these are the complications that can occur in the duodenal diverticula. So that's why the primary means which are present just itself, and usually second and third part, and usually remain asymptomatic but create little problem while doing ERCP. While the secondary diverticular, that is present due to the duodenal ulcer, so that may cause the problem obstruction as well as the perforations. Next, the jejunal diverticula. The jejunal diverticula are usually present in the multiple in numbers in the mesenteric borders of the jejunum. Clinically, there may be the asymptomatic or may produce some kind of the abdominal pain little bit, while if get obstructed and get inflamed, then cause abdominal pain, or sometime if in a large number and bigger size, then may cause some blind loop syndrome. Features of the blind loop syndrome, that is the malabsorption as well as the anemia. And if anyhow any diverticula after getting obstructed, infected, or and then perforated, then it presents as an acute abdomen and as a perforated during ulcers, or means the perforation is a acute conditions. Intestinal perforation, any part of intestine, either duodenum, stomach, intestine, colon, any part of the duodenum is if is perforated, any part of the intestine if get perforated, then it produces the peritonitis, first local, then general, and that patient may go into the septic shock. So that is the common phenomena happens in all kind of the perforation. So all kind of perforation comes under the acute abdomen conditions. So this diverticula also may present as a acute abdomen if it get perforated. Now the most important, that is the Michel's diverticulum. The exception in the Michel's diverticulum is that mostly all the diverticula are present in the mesenteric border of the intestine. But the exception is that the Michel's diverticula are present anti-mesenteric borders, means the opposite border of the intestine where the mesenteric is not attached. Understand? Means anti-mesenteric border. Diverticula are present in the anti-mesenteric border, that is called the Michel's diverticulum, presents in the ileum part. There is the rule of 2-2-2, that is in reference to, in contrast to the diverticulum. The 2-2-2 means it is common that 2% of the pupils, and it is present almost 2 feet away, that is centimeter, 60 centimeter, that is 2 feet away from the ileocecal junctions, and it is almost 2 inch long. So always remember rule of 2-2-2. What does mean? Common in 2% pupils, 2 feet away from ileocecal junctions, and length 2 inch. It is a true diverticula. Usually that are congenital means all three layers of the intestinal walls are present in the Meckel's diverticula. It has its own blood supply. It has its lumen, and that's why the problem is that it's just like the appendix. So if anyhow this diverticula, because it's almost 2 inch long, it's get obstructed and then get inflamed, perforate, so that it's the complete picture, complete presentation of the patient is just typically similar to the appendicitis. So if in case of the appendicitis means you have a case that is the typical presentation of the appendicitis, and while operation, if you doesn't find the appendix, if you couldn't find the appendix, then just to try to find the Meckel's diverticulum. Otherwise, if you found that appendix is absolute normal, if you see that after the opening, you found that the appendix is almost normal and the patient has the features of the appendicitis, then you must try to find out the Meckel's diverticulum that may be inflamed, means Meckel's diverticulitis. So this is where you found it is almost 2 feet away from the ileocecal junction. So this is the means almost the location of that the usually location of the Meckel's diverticulum. So this is the importance. It is very important because the features of the diverticulitis is almost similar to the appendicitis. The clinical presentation in 20% of cases, because the diverticulum mucosa may contain heterotrophic epithelium as a gastric, colonic, and sometimes pancreatic tissue. This is the very means the problem is that the inner layer of that this Meckel's diverticulum sometimes have the ectopic tissue, means sometimes it has the gastric tissue or the colonic tissue or the pancreatic tissue. The problem is that if it has the gastric tissue, so it releases the gastric acids, and that causes the gastric ulcerations. So the patient of that diverticulitis, because diverticulum may have the feature of the peptic ulcer disease, just like because patient has the gastric acid secretion in the colon, so that may create the gastric ulcers and that may create the perforations also. Similarly, the pancreatic tissue is there, so if it secretes the pancreatic juice, so that if along with the gastric secretions, pancreatic juice is there, and that may also causes the activation of the pancreatic enzyme, and that may start digestion of that own intestinal wall. So that's why these conditions are little more difficult and more complications have, because the damage of the own tissue and creating the ulcerations and ultimately the perforation as well as the hemorrhage. Next, the problem that occurs that due to the Meckel's diverticulum, that is the severe hemorrhage. If anyhow that Meckel's diverticulum that get obstructed or they get inflamed or get ulcers, so that ulcers may bleed, that may cause the hemorrhage, and that present as a melena. Intussusception is the conditions where the one part of bowel is invaginated into the next part of the bowel. Just like this is the bowel, and the proximal part is invaginated into the distal part. So this happening of this thing is called the intussusceptions. Usually occurs in the children's, but may occur in the adult conditions also. That the patient with diverticula are more common to means may have that intussusceptions, because there is the restriction in the movement, because the peristaltic movement, that dilation and constriction of the intestinal wall causes the peristaltic movement that may leads to the movement of the food inside the intestine. But somehow, if any particular part of the bowel is failed to relax, because when this peristaltic wave is coming to the intestine from this part, so if this part relax, then no problem. But sometimes if this part doesn't relax, remain constricted, and this part relaxes. This relaxed parts come, and so that intussusception means occurs means the one part of the lower intestine invaginate into the other part, the means the adjacent part of the bowel. So that is called the intussusception. That if the so due to the presence of this diverticula, sometimes the intestine fails to relax. That's why this happens. Next presentation may be as the Michel's diverticulum, that may typically similar to the appendix features of the appendicitis, the pain, nausea, vomiting, abdominal and abdominal pain. If it get initially, if patient has good immune system, so that the walling of by the momentum that may produce an appendicular mass. Later on, that appendicular mass may be appendicular abscess, and later on it can perforate. If not, sometime initially the patient initially it can perforate also. So the feature of the appendicitis, similar feature of the appendicitis can have the Michel's diverticulitis. Chronic peptic ulceration, that we already had discussed, is the due to the presence of the gastric layers, gastric mucosa, ectopic gastric tissue inside the Michel's diverticulum may cause the chronic peptic ulcerations. It may cause the intestinal obstruction also, because it has a long loop, lumen and the blind loop. In the blind loop, if somehow if some food is obstructed, and that may cause the intestinal feature of the intestinal obstructions. Exceptionally, Michel's diverticulum can present as a hernial sac. So sometimes, when the hernial sac have the Michel's diverticulum, that is called Litter's hernia. So this kind of, and in one kind of the hernia where that is called the sliding hernia. So sliding hernia means that retroperitoneal structures in the peritoneal structures comes in the form of the inside the sac. So in the right side, the Michel's diverticulum may becomes and the appendix may come into the sliding hernia. So this inguinal hernia may inguinal hernial sac may present the Michel's diverticulum. That condition calls Litter's hernia. Investigations. Symptomatically, it is very difficult to diagnose the Michel's diverticulum because it has so much variety of the presentations. Sometimes it looks like the chronic ulcer, sometimes looks like the intestinal obstruction, sometimes it looks like the appendicitis. So it's very difficult to diagnose initially. But if the once your patient is settled, then small bowel enema may give the uh, accurate diagnosis, because it creates the image that that's like you see in the picture. This is the Michel's diverticulum. This is the closed loop. Here the barium is filled in the loop. But they should be avoided in the acute conditions. If your patients come to you in acute conditions, so first you have resuscitate the patient, you have settled the patients, and once your patient is recovered, in that after that you can give the bowel a small bowel enema, so that you can see that filling is there, that because the diverticular filler you can see that. Or either you can send the patient to the CT. CT is most accurate and most helpful in even in acute condition also. CT can give you the better result, better diagnosis. Ultrasonography is not effective. It cannot be confirmatory say by the ultrasound that there is a case of the Michel's diverticulitis or Michel's diverticulum. Management, in most of the cases when the Michel's diverticulum is asymptomatic, then no active measure is required to be taken. Nothing could be done. Nothing is required to be done. So asymptomatic diverticula may be ignored if it is broad mouth. You know, if the base where it is connected to that intestine, if it is broad, then nothing to be done. And even in the asymptomatic cases, if diverticula has the very narrow mouth and long loop, then it can be potent source of that infections, and potent source of the intestine, this obstructions that may lead to the infection and perforation. So that is the potential site which can produce a complication in later. In that case, that Michel's diverticulectomy may be the options. In a symptomatic case, diverticulectomy should be performed. Symptomatic means if diverticulitis is there, infection is there, or perforation is there, or if any complication is there, means symptomatic cases. So that in cases the there is two procedures. Diverticulectomy, only removal of that diverticulitis. Second, the diverticulitis along with the resection of that part of bowel. So these are two measures usually taken, but that second one is most preferably done along, that is the resection of that part of the bowel along with this diverticulum. Means only diverticulectomy is not advised, because if you remove only that particular part of the that but if you remove only that diverticulum, then you, after the suturing this part, so this part of the bowel becomes narrow in, and after the healing, the fibrosis that may create a stricture, and so that the narrow of the bowel of the lumen of the bowel become narrow. So in the future, that portion may cause the intestinal obstruction, acute or subacute obstruction may cause. So the better for the better result, that the complete resection of that portion of the bowel is most preferably done along with the end-to-end anastomosis. So that operation has the most great success and less complication of the stricture formation and narrowing of the lumen. So the procedure is just similar to the appendicectomy. So in the appendicectomy, what we do, just first localize the appendix, and then first starting the ligating this the vessels of that appendix with the mesoappendix. In the mesoappendix, whatever the vessels are supplying, so starting from the tail, we just dissect one by one, close, ligate, and dissect, ligate from the tail to the base, and then we just crush by the artery forceps, and then we dissect that and close with that persistent sutures. So that's the similarly here. We are not doing the persistent suture, because here we are just anastomosing end-to-end anastomosing of the ileum. So just identifying the vessels and the ligating these vessels and cutting, and so that first the all the vessels of that mesentery are ligated, and then the part of the bowel is resected, so that particular part which has the appendix, the Michel's diverticulum, it removed, and then remaining two portions of the bowel is anastomosed end to end. So that is the procedure which has less complication, because less chance of the structure formations. Now come to the colon diverticula. Most commonly, this the colonic diverticula are present in the old age, and out of this complete colon, the sigmoid colon is the most affected part. But the diverticula may be present in the whole colon, but the sigmoid colon is the most affected part. These are acquired herniation of the colonic mucosa through circular muscles at the point where the blood vessels enters. Just similar to the jejunal diverticula, means these diverticula also present in the mesenteric border, where the mesenteric vessels enter in the bowel. So that portion becomes weak, so that the herniation of the muscular part of the bowel create the diverticula in that portions. Usually the condition, colonic diverticular condition is more common in Western world than the Asian and African world. Diverticula present in the presence of the diverticuli is maybe the asymptomatic, means the presentations. So if the asymptomatic, then there is no problem. Usually it is not recognizable with the conditions that can be diagnosed only the accidentally. But if the diverticulitis is there, diverticulitis means inflammation of the diverticula, one or more diverticula, that may create the symptoms that's all similar to the IBS. IBS, irritable bowel syndrome, means the patient has the pain in the lower abdomen. Patient has the sometimes diarrhea and sometimes the constipations. Patients has uh, less appetite and food is not properly digested. So patient may have loss of weight, and that patients may have um, anorexia also, and the condition is just similar to that. Irritable bowel syndrome is almost similar, because here the small part of bowel has the multiple diverticula that are inflamed, and due to inflammation of that part of the bowel, there that sometimes it get when it is irritated in acute inflammation, then patient may have diarrhea. Later on, the inflammation is reduced, and that creates the fibrosis. So narrowing the bowel, that may create the constipations. So that's why the patients may have the different presentations. If it is had a symptom, then it means that only diverticulosis, means there is no inflammation, so there may be asymptomatic and there may be no features. But if somehow it is inflamed, then the patients may have pain, abdominal pain, usually in the left iliac fossa, and later on that left iliac fossa, some tenderness may be there, that sigmoid mass, that due to the inflammations the augmentum is come and adherent, so that the tender mass may be felt in the on palpation in the left iliac fossa. Malaise, body ache. So these systemic feature of the inflammation can be present in the case of the acute diverticulosis. If anyhow that any diverticula may rupture and create the perforation, so after the perforation there may be the feature of the perforation, just like the other perforation, that peritonitis, and later on the patient may be going to the septicemia and the septic shock also. So here the clinical presentations: in the mild case only little distension, flatulence, and some heaviness in the lower abdomen. In the severe case, persistent lower abdominal pain, usually in the left iliac fossa, because sigmoid colon is more commonly part to involve with or without peritonitis. Means if it is perforated, then it is the peritonitis. If perforation is not there, then peritonitis may not there. And fever, malaise, and leukocytosis, loose stool, or the constipations. In long-standing cases, sigmoid colon may be palpable as a tender mass. In rare cases, formation of the vesicocolic pneumaturia or the feces in the urine, because the nearby structure of that sigmoid colon is the urinary bladder. So anyhow, if any diverticula get adhered to the wall of the urinary bladder, and if get ruptured, and that rupture and that fistula formation is there from the sigmoid colon to the bladder, so that is called vesicocolic fistula. So in that conditions, some air from the bowel, some gas from the bowel may enter to the air into the bladder. So some air may be passed through the urethra, that is the pneumaturia. pneumochuria. Pneumochuria is the condition when patient pass some gases, some air through the urethra, or sometimes the fecal matter from the bowel may come into the bladder. So that urine is very foul smelling, and the fecal matter comes with the urine also. So these conditions are the very rare conditions which can occur due to the formation of the internal fistula from the colon, sigmoid colon to the bladder. Sometimes the fistula, the skin means external fistula may be there. That is called uh, colic fistula means that fistula over abdominal wall uh, through the sigmoid colon. So the diagnosis, in acute cases, diagnosis should be made clinically. No interventions should be done to diagnose the case. That is the barium minima is most accurate, or the colonoscopy or sigmoidoscopy are the better investigation technique. But these techniques, either sigmoidoscopy, colonoscopy, or the barium enema, should not be undertaken in acute conditions. In acute conditions, CT may be advisable, because if the patient in acute condition, if you do some sigmoidoscopy and colonoscopy, then the part of the bowel, because the inflamed, the tissue is fragile. So in that condition, you can rupture the wall of intestine, and perforation may be there. That's why in the acute condition, these interventions should be avoided. First, you resuscitate your patients once your patient is stable, and after that you can do the these procedures. So in that barium enema, when your patient is settled, then if you do the barium enema, means that barium is passed through the rectal route. So you can see that sawtooth appearance, it is there. The bowel narrow, the lumen of the bowel become very narrowed, and these tooth-like structure may be present. That is the filling defect in the diverticula may be there. So sawtooth appearance may be there in case of that diverticulitis. And this colonoscopy and this sigmoidoscopy are to be done to find out that other diverticular, along with this some malignancy method, because malignancy sometimes that these diverticulosis is not a pre-malignant conditions, but malignancy and diverticulosis may be coexist. That's why if you suspect a case of the diverticula, then you must try to find out the malignancy also. You must rule out the malignancy also. So that's why the sigmoidoscopy and colonoscopy should be done. And if any mass is felt inside that bowel, then biopsy should be taken to confirm the mass. Or if any ulcer is there, so some tissue biopsy is taken to confirm if the ulcer may be the malignant or not. Treatment: in non-complicated patients, patient should be managed with a bulk-forming, high-fiber-rich diet, and antispasmodic drug should be given with in painful conditions. Means if patient is not very much complicated, then just diet is advised. Means bulk-forming diet should be advised, so that the fecal matter comes in the bulk. It is not loose, so it not goes into the diverticula and not stasis there, and infection is not there. So if the bulk is there, so it pass the lumen of that bowel easily, and the patient may be asymptomatic. If a patient has the complaint of that pain, spasmodic pain, in that condition antispasmodic drug should be advised. In acute conditions, you should first try to resuscitate the patients with the bed rest and orally nail and IV supports. Then acute analgesia with antispasmodic drugs should be given. Full intravenous access along with the broad spectrum antibiotics, especially the metronidazole and the cefuroxime group antibiotics should be given to control the sepsis. And if a patient is not responding to the medical management, then in acute conditions that surgical intervention should be advised. Either in if patient is responding to that uh, medical management, so the surgery is not advised in the acute condition. Once your patient is settled and patient is become normal, after that the surgery can be planned, means elective surgery should be advised in later cases, in cases after the sepsis is controlled. In the surgical management, there is two kind of the management. One stage resection, means that part of the colon which has the diverticula, that is resected and end-to-end anastomosis is done. Second procedure, that is Hartmann's operations. Hartmann's procedure usually applied, usually is advised in the cases where obstruction or the inflammation is happen in the bowel. So in this, the primary resection and Hartmann procedure means that part of the bowel is resected, and the Hartmann procedure is the procedure where we create a stroma outside the uh, abdominal wall in left iliac fossa, creating the colostomy, and lower part of that lower part, that is the rectum, rectoanal stump, is closed. So this Hartmann procedure is advised in the cases of the obstructed bowel or the inflamed bowel, in case of that acute in the colonic diverticulosis, and other procedure where any mass is there in the colon and you need to be resect that part of the bowel. This Hartmann procedure is advised. If anyhow the patient has developed the fistula, so in that case also you have to resect that particular part of the bowel and to repair that part of the fistula, either by colic fistula or the other fistula, intravesical fistula may be there. So you have to resect that part of bowel and close, repair that fistula. So in some difficult cases, stage procedure means initially you just producing means just disconnecting that part of bowel and creating a colostomy and closed stump. In later after the 6 months or 1 year, you again join that colostomy part of the colon to that part of the stump. Means that in stages you have to do the case surgery in stages. First stage you do the colostomy, and later stage you do the reverse colostomy. Nowadays the laparoscopic resection is done, that has the less complication and less mortality rate. So these procedures of the colostomy has a high mortality rate. You should not advisable in all the cases. First we have to try to treat the condition with the medicines. If any complication is there and medicine is not helpful, in that cases surgery should be advised. Okay, so in next lecture we discuss the remaining part.